Thank you very much. I'm going to try and give you a little bit of an overview about pregnancy scans and the different types that are available to you and why they're important. So I'll just quickly say what is an ultrasound, the benefits of ultrasound, and what are the different types in pregnancy. So an ultrasound basically works by the principle of sound waves, and so sound waves are technology that's you get a Doppler waveform from, and it will create an image on the screen, and that's how. So it's basically nothing to do with X-rays. There's no in terms of radiology any harmful effects towards the baby. So in terms of the benefits, there are many benefits which you can divide almost into medical benefits and also attachment type benefits. And if you look at the medical benefits, you've got to think about earlier detection of pregnancy problems. So early pregnancy scans are particularly used to look to make sure the pregnancy is placed in the right place. It's also good because it's confirmation that pregnancy is progressing well, and that's particularly important in people who've had problems in pregnancy before, or who even just have anxiety type issues, and I just want to be reassured that all is well. And so that it can lead to reduction of anxiety levels in the parents and help you to enjoy the pregnancy from an earlier stage. It's also improved attachment and bonding to the pregnancy via visualization and management of complications. So, for example, I've got 3 children. I very much remember the first scans that I had of my children, right down to seeing a little black sac in the womb for each one. So it's a really special moment when you first have your first scan. That special moment hopefully is there for mothers and also for fathers, and it helps everybody to be realise actually it's a real thing, because until that point, unless you've got lots of nausea and vomiting, I feel like you've got gastroenteritis, it doesn't necessarily feel that something's real. So it's a very, very special first moment. In terms of early pregnancy scanning, that's normally classified as scans that are performed under 11 weeks. And you'll normally go and have a viability scan, which will tell you that the pregnancy is viable, the pregnancy is progressing well. It will also help you to locate the pregnancy. So some people are worried that the pregnancy may be in a tube because of a previous history or previous medical complications that predispose them to that. And so that will reassure us it's in the right place. We'd also be able to work out if there's twins. If you have an early scan, it's much easier to tell if the twins are what we call either identical twins or non-identical twins in layman's terms, which is quite important for how you further plan that pregnancy. And also it leads to improved gestational dating, so making sure that we get the dates right so that we don't therefore get to 40 weeks, 41 weeks, and you're unnecessarily induced because we think you're over dates because we're sure. The other thing is that studies have shown that if you perform early pregnancy scanning, it does actually reduce the risk of miscarriage via a reduction in anxiety levels in the mother as well. So a viability scan, if you go to have it done at a clinic and it's quite early on, it's not always necessarily seen through the abdomen. So the abdomen scans are normally done later, maybe after 8 weeks you'll be able to see. So they're usually what we call transvaginal, where a probe is gently inserted into the vagina right next to the womb, and you'll be able to see the baby. And so usually you'll be able to see a heartbeat from between 6 to 7 weeks of pregnancy. And once you've seen that, actually, the chance of miscarriage are much, much lower than quoted in the literature for people who've not had scans. The reason being that for the vast majority of people, you don't actually know if the pregnancy's been progressing well until they have their scan at 12 weeks. But once you have a scan between 6 to 8 weeks and you confirm a heartbeat's present, that then increases the chance of a successful pregnancy because you've confirmed that it's viable. Sometimes if we don't see the heartbeat, it doesn't mean that things aren't going well. We've done quite a lot of study and research, and particularly out of Imperial, to show that in the same way we're all different shapes and sizes, babies also grow at different rates. And so it's important that you have a scan another week ahead of time just to see if you can see the heartbeat at that point in time. So those we'll say it's maybe a pregnancy of uncertain viability. If the pregnancy location is not always known or can't be seen, sometimes we need to do a blood test just to confirm about the rise in levels in the blood, so that may be something that's offered to you. And the other thing that you should be aware of is it's also good to know that the pregnancy is viable and to date it early on, so that if you were considering non-invasive testing, which is a test which has come up in the last few years, where they can take cell-free DNA of the baby actually from the mother's blood. So it's just a simple blood test, and they'll be able to then give you a risk factor for common chromosomal problems like Down syndrome, Edwards and Patels. So you can't really have that test unless you've had this viability scan. And usually viability scans aren't offered on the NHS unless there are any complications of bleeding or pain. So next stage would be your dating scan. So this is usually performed between 11 and 13 weeks of pregnancy. And it's at this time, we think, particularly in the UK, and if you look at all the research, it's the best time to date the pregnancy. The reason for that is because there's less errors in the measurements or difference in the measurements, and you're more likely to get the dates correct. A nuchal scan's also performed at the same time, and that combined with any further testing, blood testing, gives you a combined test risk and gives you screening for the pregnancy for any abnormalities, chromosomal abnormalities, or any other suggested other problems like cardiac problems. And as I've said, the trisomy at the bottom just describes the different ones I've explained. The other test that you may be offered, which is not necessarily offered on the NHS, is cervical screening. This is to basically evaluate the risk of actually, although everything being well with the pregnancy, in terms of the mum, if there's any abnormalities on the neck of the womb, which would suggest it's not strong enough to carry a pregnancy to term, between 12 to 16 weeks, it's good to actually look at the cervix. Again, it's probably best done transvaginally. And from the measurement of that cervix, it will give you a predicted risk of whether there's a chance of preterm labour, and you can either continue to screen or perform another test at 20 weeks just to confirm what you've seen. So an anatomy scan is something that obviously is universally offered on the NHS and also privately, and this is a really detailed scan. So this is performed between 18 to 22 weeks of pregnancy, and it will look in extreme detail at the baby. So it will look at the brain, it will look at the bones, it will look at the spine, the heart, and just to check at the movements of the baby. We'll also look at the fluid that's around the baby, which is an indicator of good well-being, a good placental function. And also it will look at where the placenta is located, the placenta's high, if the placenta's low, and give you a risk factor for any problems in that sense. The other test that is also good, and it's not always performed in all NHS units, is a look at the vascular supply to the uterus, and that's called a uterine Doppler test. If you see a notch on that, that can be a predictor of risk for preeclampsia in that pregnancy, and it will allow us to put measures in place to intervene appropriately to reduce that risk. So next thing I want to go on to is growth scans. So growth scans are something which is not universally offered on the NHS either. Some units may offer one scan, maybe around 34 weeks. But obviously within the private sector, you have that choice to be able to choose to see how the baby's growing. I just want to talk a little bit about the benefits of that. It's obviously another stage where you can look and really assess your baby's well-being, but in addition, there's lots of benefits because of the bonding that you have when you come and you see how your baby's progressing. So growth scans are normally performed at 2 to 4 weekly intervals, and usually a minimum of 2 weeks, because if it's any sooner than that, you get a lot of operator errors. And they can be performed 24 weeks onwards, and usually only from 24 weeks if there are any sort of medical indications or concerns. But we will usually check the growth of the baby, check the fluid around the baby, check the placenta to make sure it's looking healthy, and check the blood flow to the baby. And the common measurements, if you look in your scan report, you'll see BPD. That's just a measurement from the side of the head circumference is all around the head, HC, and FL is the length of the thigh bone. You also see AC as well, which is just the abdominal circumference around the baby. So those are the common measurements that people will put on the reports that you'll see. And in addition, we also do an umbilical Doppler. So again, this is another really good reassurance for yourselves and also for us as the doctors that look after you, which looks at the blood flow from the placenta to the baby to make sure there are not any changes of any concern. So sometimes we may be able to pick up what we call high or increased resistance. So just think of it as somebody who's got cardiovascular problems or high blood pressure where the vessels become very hard, and so it's harder for the blood flow to go through. So you can pick that up on the growth scans, and actually you can pick that up very early on before it has any effect on the baby, and again use that to stratify the risk and make sure that you're assessing the baby appropriately. So what we'll normally do is then you'll see a chart like this, and you'll be given, and the growth of the baby will be plotted on the chart. So you can see you've got 4 measurements there. And you can see the last measurement shows a slight dip in the growth. And that will suggest that the baby, in terms of the placenta function, perhaps it's not working so well. But we'll put the whole picture together. So we'll look at the movements of the baby. We'll look at the Doppler, as I described before. We'll look at the fluid. And we'll decide how to advise you on the pregnancy. So for a low-risk pregnancy, so routine surveillance can be performed at 28 and 34 weeks in the private sector, but for a high-risk pregnancy, we'd usually recommend it for every 2 to 4 weeks, depending on the maternal condition. So people who have problems like blood pressure, diabetes, we would always recommend for them to have regular scans, epilepsy, and anybody who's got any fetal conditions that are picked up from the anomaly scan, again, we would recommend those usually. And also in people who've had a history of poor outcome, previous obstetric problems or in delivery or neonatally, we would also recommend as well. So I just wanted to highlight to you, so there's lots of studies and research that show look at growth scans. And in particular, I think more recently, there's lots of recommendations coming out about perhaps even women on the NHS having this Doppler ultrasound scan, just because it's a good predictor and it's an earlier detection of growth problems. So unfortunately, sometimes pregnancies don't progress well and we don't have the outcome we desire. And there's lots of ways in the NHS that they're trying to look to reduce the risk to the mum and to the baby. It's not necessarily been proven that a scan can make a difference to the outcome, but most definitely can give us some insight to detect problems earlier and then actually do appropriate intervention. So if you do a scan, you're concerned about the way the baby looks in terms of size or Doppler flow, you may then say to the lady that actually perhaps a normal delivery may not be appropriate. You may actually say if you are being induced, you need to be induced on the labour ward so that we can actually monitor the baby continuously, because we know the baby's at risk of having what we call fetal distress in labour. It also helps us to time delivery. So rather than just waiting, because actually this baby, you've got to 37, 38 weeks. Now, when we looked at the growth, it's okay, but there's a slight tail off. I think it's better to do actually induce you now rather than to wait for another 2 weeks for the placenta not to work so that actually the baby can't cope through labour. And then the other thing is kind of the feel-good factor of scans. I just want to focus on a bit more. So if you look at 3D and 4D scans, they're absolutely amazing. These, I don't really think people were using them much when I had my children, unfortunately, but it's something now that almost everybody gets a chance to have. And it's absolutely amazing. It will give you insight into your baby's world. What does your baby look like? You can see babies sucking their thumbs, waving, moving around. It's absolutely, it's lovely. It also gives you a further anatomy check. So, for example, with conditions like cleft palate, you can see the face very clearly. That's got probably about 75% detection rate just with a basic 2D scan, but this gives you a better image. And it's really good for bonding attachment for mum and also for dad. So these are another few images which I thought were quite nice. You can see a baby that's almost smiling there, which is lovely. One sleeve and then a nice pair of feet. So again, reassurance. I may get a mum who actually came to me who was a bit concerned about whether her baby had 5 fingers on each hand, and you can quite easily do a 3D scan, show them the images, and it just reassures everybody, because that's one of the things you always think about, would I have 10 fingers and 10 toes? Do you mind just pressing onto the link if that's okay? So I'm just going to show you just briefly what a 4D scan looks like. Again, this is a lovely, lots of women may opt to actually keep a 4D scan as a memory of their baby. And then you can actually see the real difference when the baby comes out. So this is a 2D, basic 2D scan, as you can see there. They're showing the baby in cross-section, because you can see the baby's heartbeat and see a nice profile there. So that's what we traditionally had, a nice kick there. Again, so that's just looking in detail at the baby's brain structures, and you've got a nice profile view as well. So this is your 3D type scan, so that's a still image where you can see the baby in different poses. It depends if you've got a posy baby as well. So you can rotate the image and make it slightly better and enhance it to get a really good view. But obviously it's still a still picture. So the next thing which a lot of people will like to do is actually get a 4D ultrasound scan. So you can see the baby saying, "Oh, take the baby," having a little wave. And so this is actually the moving image that's captured of the baby, rubbing its face. And I do believe in terms of bonding attachment is really important in pregnancy, because ultimately we're here as the pregnancy show and we're focusing on what pregnancy and we're focusing on birth. But that's just 9 months and 1 day in your life, and your child will be with you for the rest of your life. And attachment and bonding, as early, if it can start as early as possible, is absolutely fantastic, and it'll help you to be able to engage with your baby as a newborn if you understand already some of its temperaments, its movements, and what it likes to do. You can even work out if your baby's a thumb sucker or not before it comes out, and work out the strategies that you might put in place. Okay, so I think that's okay. So we'll just go on to the next few slides. So I've just got a summary for you there. So just basically to overview, so 6 to 8 weeks usually is when we'd suggest a viability scan is done. So it's in preparation for if you want to have done the NIPT test, which can be done from 10 weeks onwards. And then 12 weeks is the dating and the nuchal scan as well, which enhances the NIPT. And then 16 weeks cervical length, 20 weeks anatomy scan, and from 24 weeks onwards a growth scan. And at the Portland, there are packages that you can book into. So you can have a sonographer-led package of that £300, and that does all your early viability scanning. You'd also have got a Downs and early screening package, which has the NIPT. So they do all the viability scan, and they will organise the NIPT, which is £500 for that, and the consultant-led is £600. And then you've got a growth reassurance package, where you can have 3 scans for £500, a sonographer-led, and then you've got the complete package with the prices there at the bottom. I think that's everything. So thank you for listening. I don't know if you've got any questions.
Would anyone like to ask a question? Thank you. Hi. I just wanted to ask what the difference was between the NIPT scan and the Harmony.
They're the same things. The NIPT, it's like calling paracetamol and Panadol. So that's the name of it, non-invasive prenatal testing. And then you've got different companies which have come up, which basically call themselves different names according to the test that they offer. So the Harmony is the same thing, but it's the branded test.
And is the percentage of accuracy the same, regardless of the brand?
To a certain extent, yes. They're all in around the range of 98 to 99%, so they're all very good. There is also quite a new additional test that's come up. I can't quite remember the name of it now, where they can screen even beyond the trisomies, 3 major trisomies, looking at all the a full genetic array, and that's a little bit more expensive. I think that's near £800. But yes, less broadly, they're very similar. Some will quote you slightly different results. So some will quote you a risk as in related to 1 in 100,000, whereas some will say low risk or high risk. And I perhaps would probably lean more to the ones that will quote you a numbered risk, because you can actually work out numbers yourself. Yeah.
Thank you.
Okay.
Can I ask a question, Karen? Can you see from your first scan, your 12, 13-week scan, whether the baby has signs of Down syndrome before you go and have that blood test?
Well, from the nuchal test that you have done at the 12-week scan will give you an indication, and that's looking at the fluid at the back of the baby's neck. So there are clear sort of guidelines about the levels. So if you'll get into levels, 2.9, 3 millimetres above, that gives you some concern that the baby may have Down syndrome. If it's 6, then more or less that does give you concern about Down syndrome or cardiac abnormalities. So there are features that would concern you at 12 to 13-week scan, yes.
But obviously the blood test would be needed as well to confirm
that.
Yeah,
so in that situation, either obviously the NIPT is sometimes offered on the NHS in that situation. If you've got that test done before the 12-week scan, you'll have that information. But usually if you've got concerns, you would then offer the woman a CVS, which is testing directly of the placental tissue, and analysis directly of the chromosomes, or amniocentesis, which is taking fluid from around the baby, which is done slightly later. And again, looking for fetal cells to analyse the chromosomes directly.
And I think as well, I don't know whether some couples or ladies here would have heard, with the CVS, there are concerns. Is it 1 in 100 can go on to miscarriage? What's your view on that? So
there's a generic risk that's quoted if you put everybody into one pool, but if you look very carefully, you'll find there are reduced operator-specific risks. So there will be some units have almost a 0 risk of miscarriage, and those are the units that you need to seek out if you need any of that sort of high level of intensity investigation.
Would anyone else like to ask Karen a question?
From the baby's point of view,
No, not necessarily, but you've got to make sure that the operator that's doing the scan knows what they're doing. So in terms of the settings, they have to be on specific settings, and we don't like to do too much in terms of high Doppler flow scanning on a baby early on. And so it's important that you go to the right person, because that sometimes increases the heat intensity around the baby. So it's, basically you need to get somebody who's a proper early pregnancy scanner, so they know which settings not to use on that baby. Yeah, until 12 weeks, because you can put colour flow Doppler on, but with if you put something called a power flow Doppler, that's a very different measurement, which is not as healthy 12 weeks, before 12 weeks. Yeah. Okay.
I just want to ask, is there a reluctance to measure heartbeats at about 6-7 weeks?
As in to actually measure the
Yeah,
rate?
so not...
There is. Some people do come and they quote the heart rate, but it actually makes no difference in the sense of knowing whether that pregnancy is viable or not. Because of the reasons that I've alluded to earlier, unfortunately, I think historically some people would actually say a pregnancy is non-viable, or even offer surgical management of miscarriage when it's actually not a miscarriage. So what you need to actually look at is the growth rate of the baby, some scans over a period of time. So that's why the heart rate in itself doesn't justify whether or not that pregnancy is viable or not.
Is there any possibility of causing damage to the baby by doing I don't know if it's a different sort of scan that measures heartbeat or not really?
All you're doing is really measuring the actual, so not in that true sense, unless they're using power flow Doppler, because you can use power flow Doppler to measure the heart rate, which you ideally shouldn't really do. It's because it makes no difference to the it's not going to make a difference to the outcome of the pregnancy, so why do that test? It's really to document if the heart rate is present or not. So, for example, you could just started scanning somebody and they've just got to 6 weeks. So you'll scan, you'll see the heartbeat there, but it might have only just started. So it's the cardiac myocytes that are triggering. They've got all these electrical activities. They're just at the beginning of the stage where they're establishing themselves. So you can't therefore look at that and say, well, actually, it's 80 and it should be 120, because you don't know what stage of development that heart is in. Yeah.
And at what stage, what's the earliest stage you can sort of get a measure of heart rate?
Well, you could get when you can damage the heart flow.
No, get a measure that's
Measure
reasonably sort of accurate.
from 5 weeks you can. So in some women you'll be able to scan and see a heartbeat at 5 weeks. Yeah. But in the majority of women, by 6 weeks it will be present, and some people it's 7 weeks. That's when you'll see it. So it's variable, but the vast majority is 6 weeks.
Thank you.
For example, you've mentioned a few scans, one between 6 and 8, then one at 12, then one at 18, and so on. Mm-hmm. What if I want a bespoke package with extra scans, extra blood tests, and so on, progesterone, HCG, whatever?
Okay.
Can that be done?
Most definitely. Care always needs to be individualised according to what the person needs. So if you need to scan somebody every week, and in particular around early pregnancy care, which can be really precious, I understand that in its entirety. I myself, I've had 3 miscarriages, although I've got 3 children. And we do definitely know that sometimes actually seeing the woman every week and scanning can make a difference. Looking at the progesterone, that gives you an idea of viability, again, can be hugely a reassurance to somebody. So most definitely need to individualise care. And if you need to be seen every week and that needs to be done, that can be done. But it usually will be decided with your consultants. That will be particularly a consultant-led decision rather than a sonographer decision. Yeah.
But, for example, if the consultant doesn't think it's necessary to do progesterone every week or monitor your HCG to make sure everything is progressing normally, but you feel like you want to do that.
So that's where you need to get somebody that understands you as an individual, because although it may not be strictly evidence-based, because once you've got a good progesterone that's high, it's high, and that should reassure people. If it's not reassuring somebody and they're becoming very anxious and worried, they're not sleeping at night, and they've had previous pregnancy problems, and that in itself can help them, there is no harm to do that. And that's where you need to find somebody that can support you in what you need.
And in terms of your practice, do you also monitor recurrent miscarriages or problem pregnancies? You do?
Yeah, me too.
Thank you.
Okay.
Karen, may I ask you one more question, please. In terms of the baby and measuring their weight, and I know it's very, having had two myself, my first baby was £9.10.
Wow.
But
How much did they tell you it was going to be?
well,
That's the question.
You see, this was the thing, and I think this would be the reason I'm sharing this information is I only went to a midwife twice. Well, no, I went to a midwife, but I only ever got scanned twice.
Yeah.
So at 13 weeks and then again at 20 weeks. And because I'm not very big myself, I think, and my bump was very small. Well, not very small, but it was, the midwife did her measurements and said it would probably be around a £7 baby. So you can imagine my surprise when this
surprise.
little dried up boy came out. But I felt personally, I wish, because I had a lot of complications having my baby.
I hear your story.
Another
I hear
conversation.
Your story. I hear your story. It resonates with me. I've got my colleague here, Mina Nori, and it's something I discuss all the time, actually. It's actually, even when you've got that healthy pregnancy and you end up with a larger baby and we miss it, it causes increased, I think, morbidity, which is bad outcomes to mum.
Yeah.
Also to baby as well. So, and also sometimes, in its extreme, if you get shoulders that are stuck, you can end up with shoulder dystocia as well. So I mean, I very much advocate, not everybody does. I look at the Oxford studies that have come up and look particularly at large babies and talk about inducing at around 39 weeks to avoid that particular complication that you talk about. And it's something within the NHS which is unfortunately not well recognised, and people don't necessarily practice according to that. But I feel that if you, at 39 weeks, there's not increased risk of caesarean, there's not an increased risk of instrumental delivery, actually. There's not an increased risk of failed induction, which not a lot of people are well aware of. Yeah. But if you can avoid the risk of the trauma that it causes to mum and to baby from delivering a £9 baby to a little lady like yourself, it's definitely something, £10, which is definitely something to...
But I suppose my question, Karen, is, my last scan would have been at 20 weeks.
Yeah.
And so at 20 weeks, he was measuring normal. Yeah. So I don't know what happened within the other 20 weeks. But
so you have a huge...
some sort of growth
I'll get back to your question. So you're basically asking if the scan could it help?
I just don't, for myself, and I don't know about the rest of you here, I really felt if I'd been monitored closer and if, because I didn't kick up a fuss, I had a private, I had a good pregnancy. I wasn't looking in any way bigger than I should have been. Whereas with my second pregnancy, because I opted to have a cesarean for my second pregnancy, I'm just sharing my story with you because to give you a kind of a thing. But I was definitely scanned a lot more. And it was only really in the last few weeks that they saw that he was 9.2. They only saw that big growth, So why are scans so unavailable, I guess, through the NHS? And or could we ask for more? Or is that something that we can only kind of avail of in the private
You can ask
rate?
more, but it's obviously to do with the resource pool, isn't it? So when you come and you have a lady who's actually relatively low risk from everything else, other than being just concerned that you've got a bigger baby, the resources are going to be pulled towards more the high-risk women. So a scan for what we call reassurance would not usually be offered. But definitely, a scan would have hopefully picked up the issues that you had, particularly because we know in the third trimester that's when babies do their acceleration of growth or they do their deceleration of growth as well. So as well as us looking out for babies that are going to be slightly smaller, who we need to deliver sooner, you can also pick up those babies that are now have done all their organ growth and now they're just putting on that extra fat ready, to come out. And so you can help to intervene at the right time if you know what size a baby is. So
going through the private scanning, or if you opt for the private rate or to go to the Portland or whatever it may be, you will be offered more scans after that 20 week. You did speak about that in the last trimester.
I usually scan people at every appointment that I do. I don't need to do a full detailed scan if the mum's healthy, but just to get an idea roughly of how the growth is. It doesn't take very long to do that. Just to be able to gauge. So some people were fine to carry on. Some people I say, actually, this baby's a little bit bigger. We do need to think about delivering you nearer 39 weeks. And they're very happy with that. So then you end up a baby that comes out that's, 3.3, 3.4 kilos and not 3.9, 4 kilos as it would have been predicted. With a mum who's got a very, an intact perineum. Yeah. You can't. Yeah.
I know. But I guess as well, is it accurate? So if you say the baby's looking like it's going to be 3.8 or 4 0.2 or whatever it might be.
Yeah,
You know,
it's
how
not as
accurate-
accurate. It's 20% inaccurate near term, actually. So there is an increase in accuracy. But for example, if you see a scan, you know that the baby's right on the top of the graft. It's very unlikely you're going to get a baby that's below the 50th centile, so below the graft. You still know the baby's bigger on average, and we do know that sometimes you can get it wrong, but it's important to get the right operator to do the scans who has an increased ability to pick up growth issues. Yeah.
Thank you, Karen. I
That's
hope
okay.
that helped some of you. Does anyone else have any other questions?
Hi, I'm Mona Nuri. I work with Dr Joash at Portland and Queen Charlotte's. The converse is also very important, missing the small baby. We, as we've discussed, get the 12-week and 20-week scan routinely, and additional growth scans are only offered to women who have risk factors for growth restriction, or a previous small baby, for example, or measuring small. But there are a proportion of babies that are small and we don't pick up because we just don't know it's going to happen. There's been a lot in the media recently about sort of reducing stillbirths, and I think that's a very important thing, which the NHS is very hard trying to find money for, so we can actually offer this routine to everybody, but it's still not there. And I think, as well as picking up the bigger babies in the third trimester, it's very important to also recognise that on the NHS we do miss a proportion, sadly, of babies that are small and would have benefited from being delivered a bit earlier, which you know, we can't change what's happened.
No, definitely. So yeah, unfortunately, you will get the babies that not just unfortunately pass away, but then you will get these almost like traumatic labours where you come in and you're in labour, and we look at the monitor and we're like, oh, this baby's really distressed. Everybody's rushing to theatre to deliver as an emergency. So that scenario can also be avoided, can't it? Yeah.
So labour's a stressful time for a baby. If it's a well-grown baby with great reserve, you know, that's fantastic. But if it's a baby that's been hanging in there, getting you know, as much as they can get from the placenta and just about coping, labour is just going to tip her over the edge.
Yeah.
If you don't know that, then you end up with that really, as Karen mentioned, that rush to theatre and
Yeah.
you know, what happened here. You know,
Yeah.
it's very, very hard to kind of
Yeah. Yes, definitely.
Thank you, Karen.
Okay. Thank
Is that
you.
okay? Thank you.
Thank you.